Thank you for joining us today for the Precision Medicine and Health Disparities webinar on integrating genome sequencing in healthcare systems, evaluation, implementation, and population health impact. Before we begin our presentation, I'd like to provide a few tips for using Webex so that you get the most out of today's webinar. These will be in listen-only mode. Please feel free to submit your questions throughout the presentation in the Q&A panel and select all panelists from the drop-down. I will ask the questions on your behalf during the Q&A portion of the webinar. I want to note that today's webinar is being recorded and will be posted online at a later date. We'd like to introduce Debbie Nguyen, who will introduce our speakers.
Thank you. I want to mention that today's webinar is co-sponsored by the Division of Cancer Control and Population Sciences at the National Cancer Institute and Debbie Nguyen, and that's where I'm from. We also are co-sponsored by the Center for Translational Research and Implementation Science at the National Heart, Lung, and Blood Institute, and Dr. George Mensa is here with us today to represent the Institute, and also by the Office of Public Health Genomic, Centers for Disease Control and Dr. Steve Murray, who will narrate the Q&A session. So, human genome sequencing is now increasingly incorporated into a variety of health systems in the United States. Some programs share the goal of examining genes for various unselected populations in order to identify increased risk individuals to prevent further future disease or to prevent adverse drug outcomes. Many current genomic-based screening programs examine high variability in specific genes that have been evaluated and recommended by evidence groups. Others are implementing whole genome or whole exome sequencing, part of biobank efforts linked with electronic health data. Our web centers will review current experiences as well as evidentiary, economic data sharing, and infrastructure and outcomes data requirements needed to implement and measure success in these circumstances. There'll be 20-minute presentations and 20 minutes devoted to a dialogue and questions and answers from in our webinar land, as well as from the individuals here in the room. Our two speakers are Dr. Mike Murray, Director of Clinical Genomics for Geisinger Health System. He is going to be talking about integrating genomics into a specific large healthcare system, the Geisinger Health System. That will be followed by a presentation by Dr. Greg Fierro, who's on the faculty at the Maine Department in Dartmouth Family Medicine Residency Program in Augusta, Maine. He's also an editor of Genomics for JAMA. So I will turn it over to Dr. Murray.
Hi, Mike Murray, talking to you from Health System in rural Pennsylvania. Can you hear me okay?
Are you speaking or you?
Yeah, can you hear me?
Yes. I hear you. Just as a reminder, please click on the PowerPoint presentation since you do have controls now, and then use the page down and page up arrows. There you go.
Okay, got it. Thank you very much. So I'll tell you today about our Germline genomic screening program here at Geisinger and how we based on a couple of unique opportunities that we had in our healthcare system. So opportunity to speak today to the orders. No relevant conflicts of interest to those to you. Think about stories of results that could be returned to patients who get screened with DNA sequencing in the current moment. Think about 4 different general categories. Could have returned carrier status for autosomal recessive risk. This is frequently done in the prenatal setting. Genomic results, risk scores, which are getting a lot of enthusiasm again, but I don't know anybody that's really operationalizing that. But at GUI, we made a decision to focus on monogenic risk results, and that's the program that I'm going to tell you about. So we had results in May of 2015, so we're coming up on 3 years of this program. And you can go to this URL, geisinger.org/results, to get a monthly update of the results that we've returned. It's in a downloadable PDF, which I know many of you won't be able to read the fine detail, but if you have any trouble finding this through just a normal search engine, if you don't remember the URL, just ping me. But you can easily find it on Google or other search engines. What I point out here is that this particular sheet that I'm showing now, as I said, 536 results in 533 patients. So there were 3 unfortunate patients that got results. And the categories that are on there are broken up according to CDC Tier 1 conditions, vascular genetic risk, and cancer risk. And the third page to the right there are 3 miscellaneous conditions that we couldn't fit in any of those early categories. We have focused in the early days of our program on BRCA and the other conditions, the first category there of CDC Tier 1, and I'll tell you some more about what we're finding in categories. A lot of people ask what are the particular features at Geisinger that made it a good place to start delivering kind of monogenic risk results now almost 3 years ago. So I made up a short list here of some key features. Geisinger considers itself and is considered an integrated healthcare system, meaning that same organization owns all the buildings, employs all the docs, and also an insurance product that covers about 40% of the folks that get their care here. So on Kaiser, people that don't have Geisinger healthcare insurance can get their healthcare here, and vice versa. You can have Geisinger insurance and get your healthcare elsewhere. So it's strict overlap. We have a consent for our biobank patient participants, which is broad research as well as clinical return of results. And the program, as I'll go into some details on, was started in 2007. We updated the consent in 2013 to really be in line with what we wanted to do as a return of results. And consent is available also online as a downloadable PDF, and I think a lot of folks that are looking to do similar programs have used that consent to think about what they want to put into their consents. As you may be aware, there's lots of biobanks around the country that have stored samples, but the consented patients are not eligible or haven't been consented for return of clinical results. So we were able to get a broad consent that covers both research and return. The third feature is we have a research collaboration with a biopharma company, specifically Regeneron Pharmaceuticals in Tarrytown, New York. That collaboration sequence done on all of our biobank patients, and then we've been able to build our clinical return results off of that data set. We have a mature EHR environment. We were one of the first adopters of Epic, 20 plus in place at Geisinger. It allows us to do a lot of things with tracking and messaging patients that there's lots of people around Geisinger that have been good at helping us set up this program, and I think it gives an advantage of staying in touch with the patients and getting the right follow-up to returned results. And then the last one is focused institutional commitments. The former CEO and the current CEO of the healthcare system are very committed to genomics and genomic return results, and because of that, we've been able to really marshal a lot of different groups within the institution to focus on this particular program. Made quite a difference. iCode Community Health Initiative is the name of the biobank project, which just celebrated its 10th anniversary last year. We published a summary of that in Genetics and Medicine in 2016. Dave Carey is the lead author. This is a map of Pennsylvania showing the darker areas are where the largest recruitment numbers are for biobank, and they are very much in line with the long footprint of Geisinger Healthcare System in northeastern and north central Pennsylvania. It's a rural geography, and Scranton, a major metropolis in the area, and there are about 50,000 people. So different than a lot of major academic health centers based in urban areas as far as geography. It's been expanding, and they recently acquired a health system in Atlantic City, New Jersey area, and recruiting for the biobank has started there, which has added some racial and ethnic diversity, given that our classic footprint is an area that is overwhelmingly European American ancestry. Over 175,000 participants in the biobank, and the only inclusion criteria is that you be a Geisinger patient. We have, together with Regeneron, what we call the Discover study. So not a spelling, but obviously playing on the electronic health record, EHR, there in the spell. So we announced this collaboration in 2014 and have now completed 4 years of the project. And on our announcement there, as you can see, there was a lot of enthusiasm from different including Les Biesiger at NHGRI. This collaboration, the pre-objective for both groups, the Geisinger researchers and the Regeneron researchers, was discovery research, and we've worked some projects together on others, and I have a slide there of a New England Journal paper published last year, which is an example of some of the collaborative work we're doing together. Collaborative work. Geisinger, as a healthcare system, felt that had a major secondary objective, which was to return genomic results to patients and their providers in a way that was supported both in the delivery result as well as the follow-up. And I'll talk a little bit about some of that on the other slides here. In create this return of results infrastructure and follow-up network, we had to create a lot of new groups in the organization, and some groups with insight from outside the organization. So I don't expect that everybody can read that in detail, and I won't read it to you, but certainly I can provide the slides if there's a question, and as I said, but it'll also be posted. To launch this project, we thought there were 3 essential steps that had to take place for the product and the patients. The first is a simple communication and counseling. So as a result gets generated, it gets posted in the patient's electronic health record. They're notified of the result. Then it gets directly notified by the program of the result. They're told what it means, why it's important, and talk their options for next steps. The step is depending on the gene result. There's a different specific evaluation and management plan. Obviously, if it's cancer risk versus the heart disease risk, the specifics next steps are different. The specialists engaged in the system are going to be different, but we've been able to work through the different conditions. There are 27 in total, and have a for each. The cascade testing of the patient, first relatives in particular, but sometimes going out further than that, is something that we've really made a priority of. In clinics, that's always been something talked about, but we think that we have a real multiplier opportunity here by notifying family members, both in Geisinger and outside of Geisinger. So we've been working hard at making that work. We developed, when we first started thinking about these results, what we call our 5 diagnostic groups. So hope this project's okay for you. If you work your way down from the top of that flow diagram, as a secondary or incidental result gets generated, there's then a gene-specific evaluation, as I mentioned, history, physical examinations, and testing and consultation. And then, some of the patients will veer left there into the blue area where clinical findings that go in with the genetic test result are found. So there's genotype-phenotype correlation. And some will go to the right into the red boxes, which are those where there's a genetic result but no clinical findings that go along with that at the time of the initial evaluation. And then within the blue area, we have 3 subgroups. Group 1 are folks that, when we notify them of a result identified through the program, well, of course, I already knew about that result. I've been tested clinically. Thanks for letting us know. And that's often a chance to remove what the up-to-date recommendations are for the result, and ensure that if they family members who are interested in being tested but haven't been, that we can help facilitate that. Group 2, individuals where the fund is present but no one has tested or offered clinical testing, or the testing hasn't been achieved prior to this result. So those are group 2. They have clinical findings, and then once the test comes out, they have a genotype-phenotype correlation that makes sense. Group is possibly the most interesting and most rewarding of the groups. The individuals that, when we get and then put them through a standardized evaluation, it turns out that they have subclinical disease. So we've had a number of cases now of individuals with subclinical myopathy and some early cancer diagnoses that we found through this methodology. So get into care for having the condition that they got it resulted on. Are clustered together until we really get further out from the initiation of this project, because group 5 are those individuals who won't develop the phenotype, so they're non-penetrant. Those that will develop it over time but don't have it at their initial evaluation. So individuals who have a BRCA result but don't have cancer but are at risk and will ultimately be dosed later in their life. Lots of people have asked about this group 4 or 5. How big is it? What are we for those individuals? So we're developing longitudinal follow-up plans for these individuals. We don't know how large the group will be. Obviously, time will tell which are group 4s and which are group 5s. Different for different conditions as far as the size of the group. Priorities as we were kind of out which to deliver results back on. First, we focused on the 3 tier 1 conditions, and our estimate that's playing out is that about 1 in 80 individuals has a pathogenic or likely pathogenic for one of the 3 conditions on the list. So more than 1% of individuals in our group, and this is based on analysis of our first 50,000 sequenced patients. So tier 1 conditions are familial hypercholesterolemia, hereditary breast and ovarian cancer, and syndrome. And the number estimates are listed there. Sorry if it's a little small, but familial hypercholesterolemia is estimated to be about 1 in 220. BRCA2 or HBOC is 1 in 190, and then Lynch syndrome is close to 1 in 300, and in aggregate it's about 1 in 80. So when you compare this kind of screening to something like newborn screening, which isn't a perfect comparison, but it's the potentially a relevant one, the positive rate there is estimated to be about 1 in 800. And thought about, we're doing this in our corner of Pennsylvania. If we were to do this over the entire population of almost 13 million, we'd estimate 150,000 people with a risk that could be back through this kind of a program. One of the good things about these 3 conditions is that we have strategies and methods in place for dealing with the clinical risk. So coronary artery disease and stroke risk, breast ovarian cancer risk, and colon cancer risks are all things that the health system is set up to screen for and to manage. So we're not giving back rare genetic results that sort of nobody except a couple experts has any idea what to do with. So I think that some early support from the clinical team has been because we're dealing with things that make a lot of sense that are already primary care priorities. Systems identifying these kind of risks. I can only talk about the healthcare system and Geisinger, and I'll only give one instance, which is BRCA 1 and 2. So when we went through our 50,000 cases and we looked for BRCA 1 and 2 variants, around 270 or so cases, and then we looked through and looked at how many had clinical test results in their EHR for BRCA 1 or 2. It was only about 1 in 5 of those individuals. When we did further analysis of those that had not had clinical testing, and we asked the question, how many of those met for testing but just did get it, either they weren't offered it or they never came to attention for some other reason. That was about half of the remaining untested. And then when we looked at the rest, those were individuals who they had the result, though did not meet standing criteria for testing. Comes out of multiple groups, as you know. So one of those individuals who didn't meet criteria and had never been tested was this woman who's been story publicly. She's a 57-year-old woman who's at Geisinger. She's found to have a BRCA1 result, and she was very interested in doing anything that she could to lower risk because she had family concerns that, as she said, are going to keep her for the next 15 years. And on a prophylactic salpingo-oophorectomy, she was found to have a stage 1 fallopian tube cancer, which of course is a BRCA1 cancer, which was resected at the time of what was thought was going to be a prophylactic operation. She has an excellent prognosis going forward. Her daughter is also tested positive for the variant. So that's one of those group 3 diagnoses where it was found during the initial workup and evaluation. Basically, because it looks like I'm using up a lot of the talk here, some of the work in familial hypercholesterolemia is shown here on the left. These are the maximum LDL cholesterol measured in patients in our system. In the salmon color here, the higher curve, these are individuals who are known negative for familial hypercholesterolemia variants. In the T are the positives. If you look here, here's the 200 level for the maximum LDL cholesterol in the system. Most people use a cutoff of 190 to start thinking about people who might have a clinical diagnosis of familial hypercholesterolemia. So you can see almost 40%, if you did the calculation percentage, fall below what would be sort of a typical clinical flag for familial hypercholesterolemia. And what we're finding in this group is similar to what the team at the Broad found and reported last year, was those individuals, even at the lower maximum LDL cholesterol levels, still have an increased risk for coronary artery disease and stroke. So this is an end of the spectrum that I think surprises a lot of people. We're not sure of the biology underlying it, but there's a number of theories. This is one of those things where we're identifying risk, and it's not just, oh yeah, they had a super high cholesterol. Anybody could have figured that without genetics. We're finding these individuals that we think over time we'll be able to intervene on also. Just my slide. If you take the first 14 individuals who were evaluated for having a positive variant, risk for apathy, you can see here that 7 of them had not been evaluated and had no evidence of cardiac on their chart. 7 did have past evaluations, 2 of which were considered obstructive cardiomyopathy, 3 of which were considered non-obstructive. None of these had been genetically tested, by the way. And 2 of these individuals were told they had structural heart disease, but it was due to their hypertension. So that are underlined here, you see on the next slide that following evaluation, this individual's diagnosis was changed from hypertensive heart disease to hypertrophic cardiomyopathy, genetically associated. This individual, the cardiologist, thought that there was a combination of risks involved, including hypertension, but acknowledged that the gene, which when unrecognized, was important. And these 2 individuals had new findings and management recommendations. Although we're in a court of Pennsylvania, our family members are reaching out and getting other family members tested across the country and across Pennsylvania, which is very gratifying. So thanks to our patients and participants, and I will stop there, run over.
Fiero, can folks hear me?
Perfect.
Excellent. Great. Mike can hear me at least. My slides are not up just yet. I'll wait just a second here.
You should have controls of the presentation if you just want to click on the slide and then use the page up and page down arrow.
Very good. Phil, I very much appreciate being here today to speak to you. Mike's presentation was excellent, as usual. And at this point, we're actually going to sort of step back to a sort of more 10,000 or 50,000 foot view of this topic and talk a little bit about the activities that have been ongoing recently with the National Academies of Sciences, Engineering, and Medicine Roundtable on Genomics and Precision Health. So first, I know conflicts of interest, and second, I speak only for myself, not any of the organizations mentioned in the presentation. I don't speak for the residency that I work for, the Journal of the American Medical Association, or particularly national academies. I also put in a disclaimer. I am in my office at this point in time. I tried to find the most quiet spot in the building, but there is likely to be some background noise over time. interesting. We are now at a very different spot in the slide presentation. No. No. Yeah. I think it's the end button, which results in it going to the beginning, it looks like. So you just heard is a really remarkable story that would absolutely not have been possible even 5 to 10 years ago to tell. I'd like to sort of start out by trying to impress upon you that this trajectory is really driven, I think, by economic determinism, and that's around the issue of reductions in sequencing cost and the consequences that extremely low cost, high quality sequencing has on how we think about this technology in its application to healthcare. So, getting into the framing of the Genome project, frame came up with an idea that within 5 years, sequencing would get to a point where a base pair would be sequenced for 50 cents. And that seemed very reasonable, as they had a $3 billion budget for the entire Genome project. And in the end, I think my key problem, it's set up so that if I slightly strike the wrong button, I end up in the wrong position.
For other option, if you see at the top of your screen, it says the number of the slide that you're on.
Yep.
If you drop that down, you can easily just move forward to whatever slide your presentation starts on.
Almost back to where I need to be. Many of you probably know the story. By the end of this Human Genome Project, the ultimate cost for sequencing a single genome was $500 million to about $1 billion. Clearly, at the time of publication of the draft genome, that was recognized as a cost prohibitive for research purposes as well as any intended applications to clinical use. And part of the 5-year strategic planning for the genomics community centered around developing technologies to drive costs down. And in 2003, this idea was put forward in a Nature paper that we would ultimately, potentially with advances in technologies, be able to get down to about $1,000 from a million genome. And you fast forward to today, and absolutely that goal that was set forth now about 15 years ago has been achieved. The range where sequencing a human genome, perhaps not with interpretation, but sequencing is around $1,000. And with interpretation, a genome can be sequenced for something that approximates commonly used diagnostic imaging tests. What has happened? Well, for one thing, it's had a great effect on the research endeavor. Many of you have likely heard of the 21st Century Cures Act that came into being at the end of the Obama administration. And really, the scientific visions put forward in this act and the funding would not have been possible without the sequencing costs going down to the level that they had. For the folks at NCI, the Cancer Moonshot has proven to be a real boost to the cancer research endeavor, and I think will quickly make headway on precision therapies for cancers. Again, not really possible without low-cost sequencing. And this wasn't directly funded through the Cancer Moonshot. An idea of how these low sequencing costs and their ability to apply them in clinical things has changed the landscape in our own local community here. I practice in central Maine. We have a project between our hospital and the Jackson Laboratory funded by a private philanthropic organization which seeks to sequence 1,800 cancer patients' genomes to look for potential targeted therapeutics. So, this technology, which would have been really relegated even a decade ago to only major academic medical centers is being brought to bear in small regional hospitals. Perhaps most germane to the topic of this webinar, the availability of low-cost sequencing has made possible a long-term goal of some folks at the NIH to create a large cohort of individuals with high-quality genome and phenotypic data for essentially population-level genomics research. And as this slide states, that will lay the foundation for using genome sequence data in more and more in clinical practice, as Geisinger is already doing in large measure. So, the very low-cost sequencing has also allowed a question to be asked that previously couldn't have been asked. Can sequence data be used to improve the health of large populations? About 5 years ago, I think many people were thinking about using genome sequence data in clinical populations for very specific purposes, but now with very low-cost sequencing, you can begin to think about application, as Geisinger has done, in a screening type setting, individuals who are relatively unselected for their phenotypes, with the intention of actually improving management of individuals in that population in terms of prediction, prevention, and screening, not just diagnostic and therapeutic interventions. And the federal government, U.S. federal government, has had a number of ongoing initiatives beginning to explore this space. Here is one example of the work of NHGRI through the Division of Genomic Medicine. They have funded over time a number of small, relatively small, pilot projects to begin to explore how genomic sequence data can be used in populations. For example, the Ignite Network has begun to do this around certain clinical questions that are relevant to groups of individuals. There has been an initiative beginning to explore the idea of integrating genomic sequence information into the newborn screening process, which is one of the oldest sort of molecular public health interventions, if you will. Beyond our boundaries in the United States, major health organizations like the UK's NHS have placed bets on the idea that genomics will in fact inform population health management. And as of last year, the NHS has begun a major initiative to essentially ensure that genome sequence information amount become part of the routine process of caring for patients in England. And more recently, just north of our borders, the Canadian government has announced a large program designed to begin to explore how genomics can improve population health with a $255 million award for 15 centers across Canada to begin the process of looking at the topic in their country. So we're really at a very interesting time where we have an increasing intersection between genomic medicine, personalized medicine, and precision health, and quality health care and population health. We don't really know what the overlap will be in the future. We actually have a relatively poor handle, I think, on what the overlap is at this point in time, but it's a very exciting period to be involved in this field and to begin to explore this set of technologies will actually result ultimately in expanding the bubble of quality health care and through that population health. Sometime, the National Academies of Sciences, Engineering, and Medicine has had a roundtable that has been exploring issues at the interface between healthcare, population health, and genomics and precision medicine. And in to tackle a number of the thorny questions about how to better understand and move forward the overlap between genomics health and the health of populations. The first meeting of this roundtable occurred back in 2007 and actually covered topics that were quite germane to today's conversation. And over the years, a wide variety of topics were covered that really informed this conversation. This is an event that was held in 2011. I draw your attention to the assumptions made underpinning the conversation that was held at the workshop. They're true today. Sequencing technology will advance enough to potentially produce clinical meaningful results, and whole genome sequencing will be cost-effective and comparable to other diagnostic tests. So, other topics explored over time have included evidence development, a key feature of adoption and payment for genomic and precision health technologies, developing healthcare systems. It's quite clear that for many rapidly moving technologies that are coming into clinical use, that traditional models of randomized controlled trials and decades of research before clinical adoption occurs isn't working particularly well, and the roundtable was tackled that way. We have also, in the more recent past, begun to look at issues around studying in a rigorous way implementation of genomics in various care environments, so that organizations like Geisinger and others don't end up reinventing the wheel as they in this area. Great. That are interested in what this roundtable has been working on over the last decade or so, there are 29 meeting summaries posted on the website. And for the most recent meetings, there are actually slides from all the presenters from the U.S. and across the globe, and videos of many of the presentations that were recorded. And I would encourage any of the participants that are interested in this area to browse these meetings and go back and delve into the topics. You can learn a tremendous amount from them. The delay in great. I have the slide transition there. So a number of us on the roundtable over the last couple of years had begun to how we would handle this observation that in the current landscape, there are a lot of health entities in the U.S. and actually across the world who have or are developing clinical programs that apply genome sequencing to various populations that they care for. And often these organizations are developing their programs in some degree of isolation. Sometimes they are part of relatively small consortiums that are sharing information, but we began to develop two key questions that led ultimately to a And driving questions for that workshop included how are healthcare organizations that are early adopters making the decision to try to apply genomic technologies, sequencing in particular, to large populations. Further, are there opportunities to foster increased collaborations among these early adopter organizations to study more distal translational research questions and issues around implementation of the technologies in clinical settings? And a set of questions came a workshop that was held by the Academy's Roundtable in early November of 2017, titled Implementing and Evaluating Genomic Screening Programs in Healthcare Systems. Briefly, the agenda of the workshop included 6 main elements. There was stage setting. Actually, Mike was the presenter to sort of provide an example, and then some more information about the landscape of how healthcare systems are trying to apply genomic technologies to improve the health of their populations. And we delved in several following sessions into evidence considerations around the integration of genomics into these health systems, financial considerations for implementation, and the decisions around to try to implement the technology and apply it to populations. Related to data sharing, ensuring the program meets the population's need, and actually unpacking that a bit. That's really about making sure that all populations that are targeted by a genome sequencing program actually are included in a way that benefits them, and they believe actually from the outset will benefit them to ensure the best outcomes for all. Then next steps and planning for future activities. Transitions are long here. I don't know why, but I click. I have to wait on mine for a transition.
We can pass the controls over to us and just let me know when you want to transition to the next slide.
First slide then, please. Key conclusions from the various elements of the conference. Evidence generation from all the presenters, early adopter organizations from the U.S. and abroad. All of them basically put forth that they feel that they're still very much in the mode of evidence generation. And in adopting this technology and applying it to populations is really critical to make clear what is truly research and what is a potential clinical relevance. And I think you can see that reflected in Mike's presentation. Also, to a program said that the numbers were critical. You need large numbers of individuals to sort out genotype-phenotype correlations. And the diversity of participants is also very critical to help make genotype-phenotype correlations for multiple issues, both at the sort of discovery end of genotype-phenotype correlations to sort of the applied side of whether or not you've developed solutions that actually apply subpopulations that you're caring for or not. Well, a general agreement that evidence generation remains, as it has for the last 20 years, a key element of gaining broader adoption and ongoing maintenance. Next slide, please. Next slide.
Hi, Greg. We pushed it forward.
And I see it. So yes, data sharing. Okay. Well, I think we're going to have to compress this. Actually, what I will do is, and it's still not refreshed on my end. But I'm bringing up my own slides here. So data sharing. Discussion around the points related to data sharing. There was broad agreement that there is room for enhanced data sharing across early adopter organizations, and that aspects of data sharing that need to be worked on are exactly what data needs to be shared and in what format in order to drive the research agenda forward. I think we actually skipped a slide. We also had financial considerations It was pretty clear from the presenting organizations that there were multiple avenues that they all came through to gain launch of their programs. There was not a one-size-fits-all model. At this point in time, all organizations again felt that putting their programs on evidence-based interventions was really key to ensuring that the programs could not only gain traction with leadership in their organizations, but also to long-term financial stability as insurers and other payers are apt to pay for those evidence-based interventions that actually have been demonstrated to improve population health. So, needs. Dashan really clear that the more successful early adopter organizations have a lot of effort into engaging underserved populations in their programs, from the earliest framing of research questions through to issues around reimbursement for genetic services, and that the best organizations at this point in time are engaging in active partnerships with populations they care for longitudinally to ensure that the solutions they're developing and the research that's happening really meets the population's needs. There was also a clear plea to, in future activities, remember that personal utility, not just clinical utility, has great value to a subset of the population that are cared for by the programs, and ignoring that is potentially long-term not a particularly good idea. So actions. We are able to advance slides for others. So near-term action steps. I think there was consensus that there's a need for an effort to develop an approach to data collection and sharing that include upon common outcomes and metrics for more distal translational research efforts. Ignite and other organizations have done some work on sort of more clinical outcomes, but not as much on population health-related outcomes. There was also an agreement that a group be convened to define and develop tools to help other adopting organizations do a better job of engaging and maintaining engagement of all populations that they serve as they're launching their programs for trying to apply genome sequence technologies to improving the health of their populations. In terms of FAR action steps, that would be the next slide. Around needs, it's pretty clear that many of the successful organizations engaged with payers, whether they're self-insured or getting third parties, to ensure that what the program was delivering for information about populations actually met the needs of payers to help them in deciding about whether or not reimbursement for the services for the population would occur. There probably needs to be some work for developing processes for other adopting organizations to do this in a structured way moving forward. Clearly, there was a call long-term to begin the process of thinking about how to coach new organizations that are thinking about adopting genomic technologies for population health on infrastructure needs, all the way from HR infrastructure through to personnel issues and training and education. Need tests for data models and the ability to share structured data across platforms. I believe all of the presenting organizations used different EHRs that were exemplars at the meeting, and it was clear that even within organizations, data movement is a challenge, let alone across organizations. There was a plea to think about how to incentivize data sharing, such as deposition of genotype-phenotype correlation data into repositories like ClinVar, through perhaps payments that are in part based upon a willingness to share data for molecular diagnostic testing. And also a clear need was articulated for coverage of evidence development for moving technologies that are being adopted in these populations. There may be a need for novel models where temporary payment is provided as data is gathered about the clinical or personal utility of the application. So next, please. So they're interested in working on these action steps, both near and far over time. The IOM has a genomics and population health action collaborative. Moeen is a leader of that. I would encourage you to become involved and think about how you might work to try to answer some of these questions in your organization and others. So, conclusion slide, please. First, inexpensive sequencing has made population-level application of genomic technologies for health-related purposes possible. Early adopter organizations are going to become more numerous, so they won't be early adopters, they'll be mid adopters. And economic determinism, low-cost sequencing, and the appeal of trying to apply this low-cost, relatively low-cost technology to improving population health is going to mean that expansion is inevitable. Because lots of information is being generated in clinical programs at this point in time using this technology, opportunities abound to leverage this ongoing work at relatively low cost to more rigorously answer pressing questions related to the use of genomic sequence data in population health. So, and again, I am a little sorry about the transitions in the slides. I'm not entirely sure what happened. It likely has something to do with my hospital Wi-Fi. At least I'd be willing to that.
Of the Office of Public Health Genomics, and I know you're kind of running over time, so to allow maybe up to that for discussion. I want to thank both speakers and the organizers of this webinar, including NCI and CITRIS, or Trans NHLBI, and of course the Office of Public Health Genomics, and also the 150 people of you and the line, or some of you in the room. So, I see some questions that have come in. I'm going to read some of them to you back, but if you have additional questions from the audience online, just type them in as right now. So just to start, I mean, I think, and people in the room can ask questions too. So, you know, this kind of presentation today wouldn't have been, as Greg said, wouldn't be possible if not for these avant-garde sort of the adopter institutions, Geisinger and a few others. So the question that's always on my mind, that people in public health always ask me, so isn't this a bit premature? We don't have the evidentiary foundation, you know, for population screening. I mean, if you look at population screening criteria, so you know, for me the question to you, Mike, is sort of early adopters have been kind of pushed by the cushion or the institutional sort of realization that genomics is here and it's here to stay. So we might as well begin to use parts of the genome. You mentioned at the beginning that there were 4 areas that you were looking at: carrier testing, genetic risk scores, and of course pharmacogenomics. And what you presented to us today is the approach to the single gene disorders, which collectively you have about maybe 1 to 2% of the population. So one question, what do you do with the rest of the data? I mean, is it just sitting there in the biobank? Genetic risk scores apply to everybody. Also, carrier testing affects a large segment of the population. So what do you do with that information? Is there any room for that, and that just what we get from that? Quick question. You me?
Yes. So, the answer is that our hope and intention is to expand to those other areas of return of results also. The reality is that it's money to change a research finding into a clinical result, to take it through a process to do that. And so we related that given the scale of our sequencing and the early opportunity we had, kind of the highest impact would be to find these monogenic risks. But we're very interested in pharmacogenomics and carrier screening, as well as polygraph risk scores as they evolve. It's just a matter of our priority. And then I guess the other thing is the being used broadly to do lots of research, and there is some callback of patients for research studies, but that's of course a different kind of use of the data.
So 2 questions from on cascade screening, because you mentioned you flashed a slide with the country map where so people were asking about that process, and who contacts family members, how are the costs covered, and the counseling associated with it. So can you elaborate, because that's a bit outside the usual curve of health systems, is the reach out to family members.
So on the first interaction with the patient who's receiving the results, we talk to them, amongst other things, about how many first-degree relatives they have. And it turns out, since almost all these are autosomal dominant, that there's an average 6 at-risk people in the first degree, so siblings, parents, and children. And we arm the patients with all the information they'll need to talk to family members, or to just hand them the details and have them contact us with questions. But the strategy has been to send that cascade testing through routine care. So if one of our patients comes forward to their provider and says, I have a BRCA result in the family, we support them as they go through normal clinical testing. So the costs get borne by the healthcare system.
A group of questions relevant to genetic counseling. People asking how this works. Is there pre-test counseling on everybody who is part of the bank, or you only do the post-test counseling? Because there is the research arm of biobanking, for which people consent to be part of a research enterprise. But people, do they get a counseling for all the genes that you are looking at for monogenic? How does that work before and after the testing?
Consenting process tells them that the samples will be reviewed, and that a group of experts will decide what kinds of results to give back, and we give them an example of risk or cardiovascular risk. But we don't provide any more detail or genetic counseling than that unless it's requested. So we have, have in there, I think, a line that says something like, if you have further questions, here's the number to call. So these folks can get in line and talk to a genetic counselor, but that is not a standard approach. Since this point in time, 98 to 99% of them won't ever hear from us in the near term. So not tried to counsel them.
Another set of questions relevant to the genes. So as you know, the ACMG has a set of 59 genes for return of results. I think Geisinger has 75. CDC has our top 10 for these 3 tiers. And what makes you decide which genes to return, and what to do with variant classification and the large number of variants of unknown or uncertain significance?
So our list was 76. It's now up to 80, and we have made the decision on to be fully inclusive of the ACMG list. So when that changed, we changed. It's by no means any any sort of definitive list, but we've included the ACMG and added genes that we either had local experts interested in delivering or were for we were already giving but weren't on the ACMG list. Regarding the variants, since this is an essentially incidental finding project, we're very stringent about not giving back variants of unknown significance. We only give high confidence pathogenic and likely pathogenic.
One more question that we'll take from the room here, looking at the clock. So somebody's asking, and this is for both you and Greg. Greg, I know you've been patiently silent there. So where do you see the role of public health in the work of genomic and precision medicine? Are there potential collaborations with public professionals using the population data being compiled? And I've that question was sort of my own observation because I was invited to a Geisinger Public Health Genomics Summit 2 years ago, in which you brought people from you invited people from the State Health Department, and maybe you can comment on that. And also, Greg, you live in a rural state, where we know that you have low connectivity and broadband. I apologize for that. What can you both say about that clinical public health interface? Because this is a form of population screening and it cuts across multiple health systems for that cascading enterprise.
First, I'm grateful that my audio didn't disconnect because it is, in fact, through the same web system or through the same wireless. So at least I can continue to talk, although things are still frozen from a slide standpoint. I think that the engagement of the public health infrastructure in the states ultimately is going to be very important to ensure that we don't first widen health care disparities and ultimately potentially as more and more applications become proven to be evidence-based and a benefit to improving health outcomes, health disparities. That's really, I think, a critical feature. Granted, in many states, the public health infrastructures are extremely taxed at this point in time. My own state, the opioid epidemic is essentially chewing up most of the bandwidth, I think, for the public health infrastructure. But moving forward, I think we have to be very thoughtful about how to engage that infrastructure. You probably, unfortunately, because the presentation ended up being terribly disjointed, didn't perhaps recognize that the roundtable conference on this topic really very carefully chose to look at populations that were cared for at this point in time by health systems, but that's actually only a subset of our total population health. And unfortunately, the most vulnerable are outside often of health systems and health care. And public health is really the conduit to ensure those folks are ultimately engaged and helped by these technologies as they're applied to populations.
Mike, anything to add?
I would just say that we're thinking about and trying to work towards ways to work with the public health system, but don't have any definitive plan in place.
So I have questions from the room. Dr. Mehta.
Mike and Greg, this is George Mehta from the NHLBI. Really excellent presentations from both of you. I don't have a whole lot of time, so I'd be delighted if you can point us to an existing source or any brief response that you can give us. What are we learning from how and what patients do with the results of return to them? Making decisions by going and talking with family? Are they making decisions with the care doctor or the specialist? Are formalized ways of shared decision making? And what do we know, and are there best practices of what works better?
Mike and Greg.
Just a quick response from me. One of the things that is contrary to what a lot of, maybe 5 or 10 years ago, is the primary care providers really sort of take a step back and leave it to the experts. Their support, their work, their patients to off to the experts. And I think we get to a point where you sort of have a high flow-through state that primary care can easily play a defined role in. I think they're going to continue to do that.
Just a lot. Do you follow up with patients who have received results and return the results and sort of cover according to time?
To repeat that question, I didn't hear it. I don't know if Mike was.
Right. I'm curious about patients who have gotten results returned to them, whether there's any research to or attempt to follow up with them over time. Just to piggyback on the previous question.
Well, I think probably the richest literature there, Mike, you probably have direct experience, but the richest literature there is probably in the hereditary cancer syndromes where
you have to move from Maine.
Greg, your audio is kind of starting to cut in and out.
Yeah. Well, it's a signal for us that we need to while we're ahead. Greg, we can't hear you. Mike, can you hear us? If you have something.
Yes, I can hear. We're doing a couple, follow-up studies with patients as far as their experience, their attitudes, as well as with providers. Some of that's being done through Emerge and some other consortiums we're on. Some of it's being done just at Geisinger itself.
Mike,
this is Mike Engelgel, NHLBI. Great presentation, both of you. I have a quick question, and it actually is an economic question. And we talked about how the whole genome comes on so much, but you don't always need a whole genome to just diagnose a single genetic disorder. Is it the same ballpark to do that just for one gene, or is it much less, or is there some kind of cost breakdown? Because if you just do the calculations, that envelope, you're talking about between $100,000 and $200,000 to diagnose one case of familial hypercholesterolemia, whereas maybe that's not the actual cost just to diagnose that one.
If I'll answer the question, I think what Mike is touching on, at least in part, is the economic concern and also tied with evidence, because there is some discussion out there, including part of the Genomic Population Health Action Collaborative, primarily led by Jim Evans and other groups, are targeting some of these genes with, just sequencing the genes that you want. And it can develop a chip that could measure 15, 50, 70 genes. You might be, like $50 instead of $1,000, and then you don't have to return the results that are not worthy of sort of like implementing the stuff that works, which is sort of a parallel model to a kind of a research to practice biobank-built model where you start being to return the results as they become more evidence-based. So back to you and Greg, if you have anything to offer on that question.
It's an active discussion and debate. We didn't make the choice. We had the exome, so that was easy for us. But I guess the argument for doing an exome, if you were setting up this kind of a program, is that you'd be able to go back to it repeatedly as your list or your opportunities grow, whereas if you do a defined panel, you wouldn't. But I don't think there's a clear answer on what's the best way forward.
Okay. Going with Greg, final last word, if you have anything to add to this. I think may have lost Maine. Maine is not online. So on behalf of all the organizers here, I'd like to thank you all for joining us, and stay tuned. I think we're going to have an interesting discussion of genetic risk scores next, probably in June. So thank you all, and now we tune out. Thanks.